Jesus. If you eat that during this lecture, oh, that's rude, isn't it? Hey, sometimes you just got to eat so you don't go into hypoglycemia. Okay, so that slide and what I wrote, I filled in the gaps.
That eraser didn't work very well, did it?
No, it's getting to that point. It's getting to that point. So let's talk about this insulin pump right quick. And the question was, I think when we left, how do people get their insulin? Well, animal sources and synthetics, and the range is forever. We don't give insulin pre-hospital for that reason. It takes a physician monitoring, and the problem with giving insulin is we can drive the blood sugar too low. And we know that high, if you had your choice, you'd rather have it high than too low. High over a long term though, you got serious complications. So how do people get their insulin? Well, they inject it. And they got these little bitty, what they call insulin syringes, and they're measured in units. And they pull up so much, and you'll hear terms like sliding scale. So they will compare their intake to their sliding scale, and that sliding scale, which looks like an old math thing, like remember the graders they used to use, and it would tell you how much insulin to take. That's old technology. We have new technology, and the new technology is an insulin pump. And it's even getting more sophisticated now because you'll see people wearing the blood glucose monitors, the continuous glucose monitors, and that reports to their cell phone so they can track the data of what their blood glucose is doing. And because of those type of things, Starrett, is where we're getting this information on. People are running experiments. What's spiking my blood sugar? This thing can Bluetooth into the insulin pump now, and the insulin pump can inject the proper amount of insulin based upon what your blood sugar reading is. So it's super cool. It's more of a continuous than it is check your sugar, go to the sliding scale, inject the amount of insulin. And that's what people used to do years ago. And it's kind of a pain. That's why it was hard to manage a diabetic. It's because it required so much data and calculation. So now we have these continuous monitors, and we have these continuous glucose pumps, and they'll wear the pump, much like I'm wearing this device on here, they'll wear it on their belt or on their shorts or something, and there'll be a pump affixed to them, and it's injecting insulin over in them as needed. It's a mechanical device, and mechanical devices fail. So if I've got a patient who is unconscious, and I do that assessment, and I find that insulin pump, what do you think I need to do to that insulin pump? Turn it off. Turn it off. And to my understanding, they're all easy to activate the switch to turn it off. The National Registry loves that question. What do you do with an insulin pump when a person is unconscious? Turn it off. Ding, ding. I was actually at a National Registry meeting that I was in, and that question was an example of an evolving question for new technology. And we actually had one educator in the room who was brave enough to speak up. I'm sure there were others thinking it. I already knew what the answer was going to be. Turn it off. And she spoke up and said to the National Registry test person, "Oh, so you expect our EMTs to turn insulin pumps off now? Is that where we're going with this?" Real snooty. And I'm like, "Oh, why would you, if a person was unconscious, would you go inject them with more insulin?" Hell yes, you'd turn it off. It's common sense you'd turn it off. That's an example of that old way of thinking that you still see people out there doing. Turn it off. Someone can probably turn it back on when it's needed, okay? Don't worry about it. You're not going to mess up. Turn it off. If you find it, turn it off. Because if it's messed up and it's just sitting there constantly injecting insulin, what's it going to do to the blood sugar? Drop it, drop it, drop it, drop it, drop it to a deadly level. Absolutely, you would turn it off. So that's how they get their insulin, no matter what form it is in. We don't give insulin at any level in EMS. Even though they need it, we don't give it. We treat the symptoms of, we help maintain homeostasis. We help ensure that they're breathing adequately, not oxygenating, but getting rid of the CO2. We make sure that they're well hydrated, because of the 3 Ps, they become what? Dehydrated. So the paramedic's going to start an IV on them. And give them fluids just to keep that hydration status going, help the kidneys out. Now, let's talk about this other condition. So we got hypo and hyper DKA. Here's another one of the hypers. There's so many definitions for this one. Let me pick the one I want to use on you. That's the abbreviation. That's one of them. That stands for hyperosmotic y'all are looking at me like I've got a horn growing out of my head. Hyperosmotic. Once I get this down and explain it, you'll go, oh, that ain't so bad. Hyperglycemic. Non-ketonic. I like this one better. I told you there were many names for it. Let me explain it to you, and you can make your own name if you want to. Non-ketonic diabetic syndrome. Some people say diabetes mellitus. Many ways to explain this one condition. So let's just break the words apart. Hyperosmotic. So what hyperosmotic means is sugar has a high osmolarity. It has high osmotic pressure. And when we talk about osmosis, we're talking about moving water from an area of low concentration to an area of high concentration. So we're moving the water from the cells into the vessels. We're moving water from the interstitial space into the vessels, or into the intravascular space, because that's where all the damn sugar is. Think of all your blood vessels and you put a lot of sugar in it, just like you got sugar sitting on a counter in your home or at the cafe. Water is going to want to come to it. So we pull the water from the interstitial space, which is in between the cells, and we also pull water from the cells, and it's all going into the blood. That's the hyperosmotic portion of this phrase. Hyperglycemic. Well, that goes without saying, because too much sugar in the blood causes too much of this. Okay? Here's the catchphrase, non-ketonic. That's the punchline to the joke. Non-ketonic. What does that mean? What? Without ketones, what'd you say? Not producing ketones. So we haven't turned to fat for fuel then, have we? Or this patient has it. They haven't turned to fat for fuel. Then your question should be, why not? Can anybody speculate as to why not? How come this person's got real high blood sugar, high osmolarity, but they haven't turned to fat for fuel? They don't have fat because they're young. Those are good statements, but they're not to the point.
They haven't been in it long enough?
Well, they've been in it long enough to be hyperglycemic, and I guess I should give you some deal. So a person can go into DKA, 300, 400, somewhere in there. If they stay there long enough, they'll go into that acidotic ketonic state. This person's hyperglycemic, but yet they haven't went into that ketonic state. So they are getting a little bit of insulin. They're getting a little bit of insulin. They have just enough insulin in their body to prevent themselves from going into ketosis. But they don't have enough insulin to clear it all out. You with me on that? They got just enough to keep you out of ketosis, but they don't have enough insulin to clear it all out. So as that time keeps rolling, the blood sugar graph just keeps doing this. But their ketone level stays the same. They never go into ketosis. It stays flat. This is always climbing. So this is climbing, but they never go into ketosis. So do they have the 3 Ps? They might have one of them, probably the polyuria, but that's just a fluid issue. We're talking blood sugars well over 700, 800, 900, 1,000. I picked up a gentleman one time in Bonham that when I checked his blood sugar, it read HI. Now I've had several patients, it just reads HI. When you use the glucometer and you get the sample, it says HI, means high. Or you may get one that says LO, low. It means you've just exceeded the parameters of the device. And each device is a little different, so I highly encourage you when you go to work somewhere to know what the cutoffs are. Above 600, this thing's gonna read just HI. It's too much for the machine to manage. You'll get them to the hospital, and sometimes they'll go do a finger stick blood sugar right there at bedside, and they get it, and they'll get like high, just HI, high. It's too high. So they will draw a sample of blood in a vial. They'll take that vial to the lab, and they'll dilute it 50%. They'll put 50% normal saline in there. Shake it up, test it again. Whatever number they get, they'll double it. So when I picked this guy up, his blood sugar said high. I'll tell you more about his story in a little bit later. They took it to the hospital. They cut it. I think he was 770 after they cut it. Now, he was a very interesting case because he was self-managing his diabetes. He was buying his insulin over the counter at Walmart. He was not seeing an endocrinologist. He was not under care. He was trying to manage his diabetes at Walmart by buying it over the counter, and he quit going. And he lived alone. He was about in his late 30s. He lived alone, and he got himself in one hell of a situation. And when we got there, he was so near death. He was so dry. His eyes would not blink. You could see him trying to blink, but they would just tug at the eyeballs. And they were furry looking, and his tongue was furry looking, and it was curled up, and his eyes were sunken in his head, and his temples were sunken in. He looked like a corpse. And his skin was so dry, it was real easy to see his veins because his skin was so just kind of like a weightlifter does, a bodybuilder, when they cut before they go for a show, they purposely put themselves in that state of drying up so everything's more pronounced. Well, that's how he was. I stuck him with the IV, and I didn't get what we call a flash. I didn't get blood coming into the catheter. I'm like, I know I'm in that vein. And I pulled the needle back out, and I got a drop of blood there, and that's how I got my sample. It wouldn't run. That's how dry he was. It wouldn't run. And we got him to the hospital, and they checked his blood sugar, and it was upwards of 1,400 plus. And his sister had found him, and that's how I got the information. He couldn't talk, and I suspect he died later. I don't know his outcome, but I suspect he died, probably a kidney failure. That's how dry these patients can get. When you find someone that condition is often found by EMTs and paramedics. When they get this insane blood sugar and the patient doesn't look good, and you ask them in their sample history, are you a diabetic? No. No. It's just because they have been running on so little insulin for so long, they really didn't have the symptoms of diabetes and never went to the doctor about it. They knew something was wrong. They were tired all the time, fatigued, just didn't feel well. Just a sickly person. And by the time the symptoms get severe enough that they call 911, that's when you discover it. And you can say with some degree of certainty, well, you are now. When they say, I'm not a diabetic, and I'm like, well, you are now. And so you get these symptoms that go along with this, but you don't get any of the ketonic symptoms. You with me on that? Is this one bad too? Absolutely. Absolutely. That insane blood sugar. Remember, 1 teaspoon difference between 80 and 120, and that's where you should hover, and we're in the 1400s. That's like your triglycerides should be below 100 and they're 900. There's a lot wrong there. A lot wrong. So we should talk about treatment, not that we haven't already. Low blood sugar, get them sugar. High blood sugar, get them to the hospital, get the insulin brought down, or get the insulin in them to get the sugar down. It's really that easy. It's really that easy. Do we care how they get their sugar? As long as they get it, we don't care. What 2 routes can we give them sugar? Oral or IV with ALS. And the role of giving them glucagon is just to release the reserves if they have some. If the person has their own glucagon kit, kind of like your guy had his own little kit in your own scene, and you see that they have a glucagon kit and they're unconscious, it is perfectly legal for you to get on the phone with Med Control and say, I have a diabetic patient who is unconscious and they have a care bag, or mom brought me glucagon. I'll almost guarantee you that physician will give you orders to give it, but you have to ask because it's outside of your scope. Will glucagon always work? No, they had to have the storage first. Any questions before we leave this?
Could you give me a sample question on how the test would ask a question about this?
They'll probably try to make you think they're having a stroke or a seizure, and you didn't check blood sugar. Another sample question will probably relate to you're on scene, a patient's unconscious. During your secondary assessment, you have discovered the patient is wearing a glucose monitor with an insulin pump. Your next best action would be to turn off the pump. But if they had vomitus in their airway, your next best action would be clear the airway. You with me on that? You see, sometimes they prioritize things. Somebody, it was you bringing up athletes, bodybuilders, weight loss. Sometimes they dabble in the hormones such as insulin to try. I knew a guy who wanted to make himself really cut, and he would inject insulin in himself. It's not a thing to do. And now they're doing it with the peptides. So the new thing to lose weight is the peptides, which is really just stimulating a hunger hormone in your gut to say you're not hungry. So it's still a jacking of the hormones. So people will do that to meet their vanity goals, if that's a word. These people are pretty smart at that to some degree, but they also can get themselves in trouble if an amateur goes out and thinks they're going to lose weight by taking insulin. Are all insulin-dependent diabetics fat or obese? No, they're actually very skinny, oftentimes very skinny, because they've been using up that.
Since he was a strong guy, but as soon as he started doing insulin, he got
Mm-hmm.
So it does work.
Yeah. Well, it's you've got to burn up the sugar. You've got to burn up the sugar, and there's a lot of research that says the best way for a diabetic to manage their blood sugar is after they have their meal, go walk instead of take insulin. Delay the insulin while they walk, because that burns up a lot. If you see Mr. Blaine walking at lunch every day, he'll walk 20 or 30 minutes after every meal. He's getting his time in to keep his blood sugar regulated. He's not diabetic. He doesn't take insulin. He doesn't take oral hypoglycemic agents. He's managing it with diet and exercise, even though he likes the sweet, just like any of us do. But he knows that he's super sensitive to that, and he'll burn it off. So you can eat that stuff if you burn it off to some degree. Okay, let's spend the rest of the time talking about our hematological conditions, and that is the rest of your PowerPoint, or rest of this chapter, I should say. And thank you, Frank. Why don't you just run this for me, because I never do know when to advance. I can't read these things. I guess it's one of those things that I can... that's another definition for this, HHNS. They don't tell you what it stands for, though, do they? That's osmotic hyperglycemic non-ketonic syndrome. I hate slides. No one's got any questions? All seizure patients get what? Blood sugar check. All right, let's talk about these conditions right quick. Hematological emergencies just means issues you may encounter because someone has an issue with their blood. These are just emergencies dealing with diseases of the blood. And we'll take the first one called sickle cell disease. Okay, historically, in the literature, this has been reserved to people of African American descent. Genetically predisposed to it. Now, the genetic predisposition of that is true. There are white people who have sickle cell, so it's not singling out a certain race. Is it more predominant in that? Yes, because of the genetic descent, but it doesn't rule it out in other races. Sickle cell disease is when the body builds red blood cells, it builds them wrong. Normally, the red blood cell looks like a torus or a donut, and you didn't knock the donut hole out, you just flattened it in the middle. Are you with me on that? From the side, it would look like, and that would be a red blood cell from a side profile. It's a donut, but you didn't knock out the donut hole. From the top, it would look like that. Well, a sickle cell looks like a sickle. You say, well, what's a sickle? Well, a sickle is what people used to harvest wheat with, to cut the wheat down. It was on the long stick, and they would swing it. And it was just a knife blade, a curved knife blade, and they would swing it, and it would cut the wheat down. I'd hate to do that all day, wouldn't you? Over thousands and thousands of acres. You'd have some abs, wouldn't you? That's all you did all day long, is cut wheat down. It's probably a better job than the person who would go gather it up and tie it up in a bundle to stand in the field, and those were called shocks. And they would stand them up in the field and let the wheat dry. Combine does all that now, that and herbicide. So people have these misshaped red blood cells. And as they go through the vasculature, because they're not rounded, because they don't tumble and slip by each other, they tend to like clog up. Well, what do we know happens when the blood clogs up? Clots form. So they're real high. They have a real high propensity to make clots, and these clots hang up in the capillaries, like the joints, and they hurt. And it's this arthritic type pain wherever they may have these clots forming. And I would have to say that in my field experience, people with sickle cell disease are struggling drug addiction as much as the disease. It's very common for these people to be addicted to drugs, especially if they have low economic status, social economic status, where they can't afford to take care of themselves or have a family unit that helps take care of them. They're often unemployed because they just can't hold a job down because they hurt so bad. It's disgusting, if there's a better word for it, I'll use it, to watch somebody degrade that's in that position. And unfortunately for you as EMTs, they will become your frequent flyers. They are the people. It's just that the pain becomes so intense that they can't stand it anymore, and they hope like hell the emergency room will give them something strong for it. Some physicians in the emergency room are very generous with that. Some physicians say, you're just drug seeking, and I've given you too much, and you've had too much, and you're not taking any more. Well, if they can't get it there, they're going to get it somewhere. And I knew a lady who was a frequent flyer who had sickle cell disease, and she turned to prostitution to get her drugs. She constantly had a chronic, long-term ulcerative sore on her inner thigh or inner calf down here. And every time I pick her up, it would just get worse and worse and worse. And she self-treated that open wound by packing it full of Vicks Vapor Rub. And so she constantly smelled of Vicks Vapor Rub. Her name was Opal, and Opal died. I was the last guy to pick Opal up. She was ran over by a car. And I was of the concept that when I got called to her address, I knew who it was. We frequently flew on her so much that I could fill out her demographics before I got there. Her name, her social, her birth date. I don't remember them now, but I would just go ahead and fill all that out because we've done it every shift. She would visit TMC, then Wilson & Jones, and Medical Plaza. She would just rotate around. She would get somebody to take her to a payphone. I don't know if any of you know what that is. She'd go to a payphone, and she would lay up in the payphone booth and call 911 a block from the hospital. And you're like, Opal, how'd you get to the payphone? My uncle took me. Why didn't he take you all the way to the ER? Well, if I go by ambulance, I'll get in faster. And the ER staff would be like, either put her in the waiting room, depending on the doctor, no, bring her right on back here, she's hurting. And so I was in a really bad way one night, and I'm like, I am so sick of Opal. I am so sick of picking her up. She knows which doctors will give her the medicines, and that's when she wants to call. So I would know earlier in the day who was working tonight in the ER, and I'd know we were going to go get Opal. She knew the doctor's schedules. And so I told him, I said, you know, she doesn't come here when the other doc's here. She only comes here when you're here because you give her the medicine. And you go in there and talk to her. She's abusing the system, blah, blah. I was just in a bad way. And he come out there and said, you ever had sickle cell disease? I'm like, no. He said, well, neither have I, but it must hurt. Have you seen her leg? Yeah. Do you know what she does with her legs to get more drugs? I'm like, oh, God, don't go there. Do you know she takes her prescription painkillers, count of 100, and go trades them for a count of 5 high-powered ones? That's why she never has her medicine? No, I wasn't aware that's what she was doing with her medications. She's drug dealing, she's prostitution, and she has sickle cell disease. It is a horrible disease. Like I said, some people who have good management, those who have bad management, it is a terrible, terrible disease to watch. In the males, one of the symptoms is priapism, and priapism is defined as a constant erection without sexual stimulation, because the sickle cells hang up in the capillaries, the microvascular of the penis, and it can't drain. Does it hang up in the eyes? Blindness. Does it hang up in the kidneys? Kidney disease. It's just a horrible disease to have. Now, it's a recessive trait. In order to get it, both parents must be carriers for the offspring to get it. So at that genetic makeup, it's a little more, it's not just widespread. It's not dominant, and it takes 2 carriers. So it's not widespread, but it does happen. Management, supportive. Can they have PEs? Sure. Can they have strokes? Sure. Do they have clots in their legs? Sure. Do they have a high infection risk? Sure. Anything I can do about it? No. It's supportive. But please don't demographically isolate this. Anybody could have it if the genetics work out right. Hemophilia A, B, C, on down the alphabet if you want to. Hemophilia just means you've got a clotting disorder to where your blood doesn't clot very well. If you find this in somebody's history following a trauma, it's going to be really hard to control their bleeding. If they got a history of this and they fall and hit their head, it's just like being on the anticoagulants, the Plavix or stuff. So bleeding control becomes an issue. Spontaneous bleeding becomes an issue. And these people, all these are managed through blood transfusions and stuff like that.
So does it start in the bone marrow? Is that where it starts?
The bone marrow makes the red blood cells.
Is that where the problem lies, or is it down to the
I don't know. I think depending on which one of the A's or the B's or the whatever is probably where the root cause of it comes from. What's it matter for us? If a patient says, I have hemophilia, it's going to be really hard to control your bleeding if it starts. If I'm a paramedic and they're hemophilic, I better be damn sure they need that IV before I start one. And it's treat it like somebody you would treat who's taking Plavix or aspirin a day or too much aspirin or something like that. They just don't have the clotting factors, if you will. They're clotting factors that are activated when you get a wound or a cut. And theirs just doesn't work. It's not activated. You don't get the there's thrombinogen, which is genesis to create a thrombus. That doesn't work. It's the direct opposite of the next one on the list, the thrombus issue. Thrombophilia. It's kind of hard to say. Thrombophilia, you're on the other end of the spectrum now. You went from a free bleeder to a clotter, somebody who clots too much, too quickly. These issues show up a lot in pregnancy. So when a woman has either one of those issues and she's pregnant, you've got a really high risk of pregnancy there. What's it mean for us? Deep vein thrombosis will show up, strokes will show up, kidney disease, heart disease. You just got too many clots through the body. And once again, blood transfusions are often indicated routinely for people under these conditions. If we don't have the clotting factors, we'll give it to a hemophiliac. If you got too many clotting factors, we will drain some blood out and give you and replace it with some normal blood for a while. Same way with sickle cell disease. Let's get rid of some of these sickle cells by taking some blood from you and put back a donor red blood cell. And so you can see how this would be a toll on your lifestyle, and it costs money to do that. So if you can't afford it, you're in bad way. And then the next one is anemia. Now there are many forms of anemia, but basically anemia means something's lacking in your blood. And for the purpose of this discussion, we're going to call that oxygen carrying capacity, iron deficiency. So what is the element that's on the red blood cell that carries the oxygen? Iron. Iron you get in your diet. You have to consume iron in your diet in order to prevent this. Women who have their period, menstrual flow, tend to be more at risk for anemia than those who don't, or those who are male, because they're losing blood. So it's super important for a menstruating female to make sure they have adequate iron intake. And the easiest way to do that is to cook in cast iron. That's the easiest way to get it. Just get it through your cooking utensils. You shouldn't be cooking in anything like a non-stick skillet anyway. That's highly poisonous, and I encourage you with everything I've got to destroy any non-stick skillet you have in your house. Do not use them. They are the most hormonal disrupting agent you can ever get into your body. Go buy you a cast iron skillet. Do not.
Is that what you were talking about that time?
Any of them. They've already banned the Teflon ones, but the other ones aren't any better.
Have you watched that movie on Netflix? You should watch it. It's called Dark Waters.
I know Teflon and nylon, all from the DuPont company, is why hemp and marijuana was illegal in the country for so many years. It's through the lobbyist of those people.
Go watch that movie. They murdered like 24 cows and an entire family. Try to cover it up.
Mm-hmm. Do not use non-stick skillets, non-stick cookware. So you need to pick the iron up in your diet, and that's an easy way to do it, or iron supplementation. Pregnant women take iron. If you're having a lot of dysmenorrhea, you probably are anemic. And sometimes I get in trouble I look at a female in the classroom, I'm like, you're on your period, aren't you? Because you're not feeling well, and I can tell by the color of your face. And they're like, that's kind of private. How did you know? And I'm like, well, you're demonstrating it because I assess people, and I can tell today that you are deficient in red blood cells. You're sick. You're ill. Your blood is out of balance, and I can tell. And you'll start being able to tell too when you start seeing a whole lot of people and you start observing people. And I don't necessarily want to, but I know you don't feel well. You see that dark circles come under the eyes, the pale face, the lethargic. What does that mean for us as EMTs and paramedics if someone is anemic? Well, the biggest thing is oxygen carrying capacity of the blood is down. That's the biggest thing. Some of the components are, depending on the anemia, you may not just have enough red blood cells. There's all kinds of anemias. Pull out something from the blood, and you can put the broad category of anemia on top of it. So you kind of got to know what they're missing. Are they missing platelets? Are they missing white blood cells? Are they missing red blood cells? Are they missing iron on the red blood cells? So it's a big spectrum of things to get into. And you'd have to know specifically what anemic condition they're suffering from. So if you can't get the the saturation up real high, or the patients don't improve on oxygen, and they got a history of anemia, that may be the issue there. Questions on that? Not a lot we do in hematological emergencies. A little bit more in the paramedic side of things, because sometimes paramedics transport patients who are getting a blood transfusion, like from one trauma center to another one, and they have to be on the lookout for transfusion reactions. At the EMT level, you hardly have to deal with that. So you'll get into this much more when you go next door. Questions on those? It's a lot of information today. But I think you'll be okay. Luke, seem to have questions.
I was gonna ask how you treated somebody with low blood cells. You said give them iron.
Low iron on the red blood cells, they need iron. That's called iron deficiency anemia.
What if they're just low on blood cells? Like without
Then they have the hematocrit is low. So what you're describing there is they have per volume a lower number of red blood cells per volume. And so they need red blood cell production to increase. And that takes a toll on the body. You got to be well nourished. You got to have the hormones that say bone marrow do it. Your bone marrow have to be functioning. So we don't do anything about it. If you go to the hospital, they're going to give you packed red blood cells. They'll just use a donor to give it to you and then try to find the cause of why you're not making enough. Some people, I think in your question, we're going to get into somebody without enough red blood cells because they've lost them. And sometimes the loss is obvious because they got trauma, but sometimes the loss is less obvious. They've been losing blood, when I say internally, like into the GI tract. They've got a slow leak in their intestine or something, and they've just been pooping some blood. Irritable bowel syndrome, Crohn's disease, diverticulitis, ulcerative colitis, duodenal ulcers, gastric ulcers, and they just lose a little bit of blood all the time. I had a paramedic student, and I see them, when I was teaching paramedic, I saw them over a year. I'd see them August to August, and I watched a guy come in August who was kind of like you, taking care of his body, working out, going to be a firefighter, became a firefighter before January after Christmas break, congratulating him on his new job and everything. And I'm like, are you feeling okay? Yeah, why? I said, you don't think you feel okay? He's like, well, I'm tired a lot. He said, but I just started that job and I'm not accustomed to that shift. And then school and Christmas holidays and wife and kids, I'm just ran down. I said, okay, you just don't look good. Rock on around February, I'm like, you're not looking any better, you're looking worse. And he had the dark now. His darkness was starting to fall in. He was super pale. He said, I can't get enough sleep. I was finding him at lunch. Instead of going to lunch, he'd curl up in the corner and turn out the lights and sleep in the classroom until I came back in. And we felt so bad for him, we were leaving him alone. It's like, let the guy sleep, man. He's messed up. You sure you're feeling okay? Sure you're feeling okay? One day, he said, I need to talk to you in the hallway. Okay. I said, what is it? He said, I just went to the bathroom and I pooped a lot of blood. I'm like, okay, makes sense. I said, you need to go to the doctor. And he said, no, I don't want to go to the doctor. I just started the job. I don't have any sick leave built up. Is there anything I can do? I'm like, yeah, go to the doctor. So he went to the doctor and he had a lower intestinal bleed. He had ulcerative colitis. And they put him on mega doses of steroids to drop the inflammation and stuff like that out of the colitis. He almost ended up with C. diff as well because his gut became so porous that he had a little touches of that and had to get on some antibiotics and things. And you know, if I say diet and lifestyle and stress, I'll have someone who has ulcerative colitis say, that's bullshit, you just get it. But I don't know. Opinions vary on what causes it. We didn't lecture on gastro stuff, but third world underdeveloped countries have none of that. Those diseases, ulcerative colitis, Crohn's, diverticulitis, irritable bowel syndrome, they have none of that. None of it. It doesn't exist in other countries. It is a westernized society disease. So you tell me where it comes from. What's the difference in ours and them? It's what we eat. It's the processed foods. It's the antibiotic overuse. It's the stress of the lifestyle and stuff like that. What are y'all looking at up there?
Oh, we're sliding through.
Oh, okay. It's up there available for you, but yeah, go right ahead. Go right ahead. Did that answer your question? What causes it? I bet there are many, many, many factors. But celiac disease, gluten sensitivities, those do not occur anywhere else. But people who have adopted the SAD diet. And I know people who have celiac disease and what they try to eat to avoid the gluten, and they're still not healthy. It's because they're following the recommendations of the Celiac Association, which is limit your red meat intake and buy the oats instead of the wheat because there's no gluten in it. I know a guy who can't even use certain soaps because they put gluten in certain soaps. He's got a new baby and there's gluten in diapers, he discovered, oddly enough. So they're having to buy certain diapers so he can at least change his newborns. He touches them. And when I say he's sensitive, touching them puts him into a fit of nausea and vomiting, allergic reaction and breaking out and difficulty breathing and that kind of thing. So it's not fun to live like him either. Any other questions? Before we depart for the day, I'd like to check my email about something, all right? That may pertain to you.